My name is Mark Cannon. I'm a professor at Northwestern University, Feinberg School of Medicine, Department of Otolaryngology, Division of Dentistry. Well, that's a lot, you might say, but the most important thing is I'm a practicing pediatric dentist. And I've been in the same location for 35 years, so I have a lot of second-generation patients, and that says a lot to me. That's why I'm trying so hard, as much as you can do, to the best I can in pediatric dentistry. I'm also the research coordinator for Ann and Robert Laurie's Children's Hospital, Division of Pediatric Dentistry, and I have the great privilege of working with some of the smartest and youngest people and nicest people could ever work with as residents. And we do a lot of very interesting research. Now, I've been there since 1978, and I've seen Children's Memorial Hospital grow and blossom and have the latest in technology. And I will show you right here the beautiful hospital. You see my cursor there on Ann and Robert Laurie Children's Hospital, which is a state-of-the-art, beautiful facility right in downtown Chicago, right next to Prentice Women's Hospital. And there, that little building there is the American Dental Association. Now, the quality of care in pediatrics has skyrocketed because of all the new technology, especially in diagnosis. And they provide outstanding clinical treatment there. You know, Northwestern University is one of the finest medical centers in the nation. And we have some of the top specialists in all of the specialties in pediatrics there. Providing this outstanding care requires the latest in technology, and that's what I'm going to talk to you about today. Now, I mentioned research, and a lot of the things we do in research is actually disprove myths. And that's kind of like quoting our good friend Stephen Hawking here when he said, right in advance of the slide, there we go, the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge. Now, Stephen Hawking, when he said that, he was referring to a lot of the myths that are believed that are just that, myths, and they have to be disproven. So what do we do in pediatric dentistry? We try to provide the best in dental care for kids. That's what we strive for, and that requires us to use the latest and finest in diagnostic technology. Now, as you know, pediatric dentistry is goal-based. It's not like the other specialties that are treatment-based. Pediatric dentists provide all treatment for an age-based group, along with care for those with special needs. And that requires us to have a lot of good diagnostic information. One of the new things we have as a pediatric diagnostic aid is the CAMX Spectra. Now, the CAMX Spectra caries detection aid helps us to diagnose problems early on. That improves our preventive program because we can target the patient's specific needs. We can actually, as you know, remineralize, reverse small lesions, or arrest even larger lesions. But more important than that, it allows you, the practitioner, to evaluate over time how successful your preventive care program is. How well does it actually work? You can now put a number on those lesions to see how well your preventive care works. Now, another aid is, of course, having great diagnostic radiographs. We really need to have good x-rays. But with kids, you have to be able to do it with comfort that you had with the old films, the flexibility that the old films had. You just can't use these large and thick CCD sensors comfortably on little kids. And of course, the same issue is true for those patients with special needs because, as you know from default, pediatric dentistry is also the specialty of special needs care. When we get done with this little discussion, I hope that we can talk a little bit about what I feel are the superior diagnostic capabilities of the CAMX Spectra unit and how, in practice, it works well to be able to accomplish the x-rays you need when you need them. Now, I have to tell you something. It just happened this morning. A new patient came in at 11:30 this morning with me. She had been seeing a dentist for 4 years, but her experiences had not been the best, to say the least, from what I am told. And one of the key issues they had is they could not get good radiographs on her because of using thick sensors. So diagnosis of decay was delayed. She now needs a pulpotomy, many other restorations, and this we could prevent if we use the right diagnostic equipment or radiographic equipment. They can't be in practice for 35 years without, being the senior partner of a practice, without having a feeling for what is the right investment. When we purchase equipment, we have to think in terms of cost, mainly because we want to keep our fees fair for our patients. We have to keep things reasonable so we have improved access of care. We also have to be able to reimburse our employees what is a fair wage and give them the benefits they deserve. So when you pick up a unit that can do an excellent job at a lower cost, that's the right thing to do as a practice manager. And this fits the bill. It's relatively inexpensive and it works well using reusable photostimulable phosphor plates. Let's compare them to the CCD rigid sensors. First of all, the thicker sensors come in a very limited range of sizes. One thing you always have to deal with is a USB cable coming out of the back of them. Now they are fast. Images can show up in 2 seconds, and the resolution is good. The lines per millimeter may be up to 33 lines per millimeter, but they cost, $9,000 each. They're not inexpensive. And then you have insurance costs also. You can compare that to the PSP, the phosphor stimulable or photostimulable sensor plates, and they're thin. They come in the same sizes as film. There's no cables, so they're wireless. If you use a good unit like a ScanNet Swift, you get the images like in 7 seconds and you get very good resolution. So there's a lot of benefits to using the ScanX PSPs. And you get a much bigger image. You have more image area, 17 to 38% bigger than that of a CCD. And since they're so much thinner, 1/30th the size at 0.4 millimeters, it's so much easier to get them in the right position. There's greater comfort, and of course you can get a better radiograph that way. So when we say watch the gaps, you guys from one riding the tube, we're not talking about the tube. We're talking about the gap you get when you use a CCD sensor, because you have that chip that is square. Edges may be round, but it's still a square chip. And you cannot bite into occlusion for your radiographs because you have that cable hanging out. So you're kind of limited on the quality of your radiographs. What do other dental professionals say? Well, a survey done in 2013 of about 1,300 professionals, and he said 1 out of 3 found that the hard, rigid sensors were difficult to place and get the area and the image they desired. 55% said that sensors were pressing against the tori and being very uncomfortable for their patients. Well, I would think that would be true for everyone, not 55%. I just saw a young lady who's 14. She has 2, just an hour ago, and she had 2 nice mandibular tori growing. And, that was just an hour ago, and she's only 14. What do you need to run ScanX? Well, you have to have an acquisition computer. It doesn't have to be right there. It can be anywhere. We'll show you some pictures of that. A good imaging software, personally, we use Apteryx X-Ray Vision at the office, your standard office network. And like I said, you don't have to have a workstation in every operatory. That's kind of nice. I mean, you can have open bay areas with one workstation, be able to just acquire the x-rays there and not have one for every chair because the length of a USB cable limits you. And we did say a standard x-ray source, so no, I'm sorry guys, nuclear meltdowns don't count. If you have one in the neighborhood, you don't get free x-rays. How about resolution? Well, there's a reason why ScanX has gotten so many dental advisory awards, 2013, 14, and 15. very high resolution, up to 2000 dpi. And if you look at it, the clarity, the resolution of the ScanX PSPs is superior to that of that regular X-ray film, so it's better than what you used to get with conventional films. And it's as good as the wired sensor, so you really have nothing to lose with using a wireless PSP. But you do lose the retakes, because a survey again done showed that 25% of dental offices do 4 or more retakes a day with a hard, thicker sensor. Well, that's something to consider, lack of retakes. Let's go back to pediatric dentistry, and let's talk about some basic dental care protocols, which is the basis for what we're doing this for, right? Well, what's your minimum requisite for an infant exam? Infant exams are the exams done at up to 3 years of age. And the first thing you want to do is get a good maternal child dental history. Of course, you have a medical history. That's a given. And you want to really deal with the questions and the concerns of the parent, because you want them to understand why they are there, why it's so important to start at age 1. Something I was first exposed to in the early 1980s was the age 1 visit. I've tried so hard to be a proponent of that ever since. You give them a reason to be there. You explain the necessity of it. Give them the background, why they need to have a dental home. You need to make sure you do a good, thorough examination, and you can do a prophylaxis if necessary. You can do a varnish application. We use MI fluoride varnish from GC. And you inform them of the use of xylitol, and that's very important. Now I'm going to go back to the exam for just a second before we go on to diagnostic tests and give you a little personal history. Tommy. That's why I have Tommy there. In late fall 1978, I had a patient in emergency on a Sunday, a 14-month-old I went in to see, with what was reported to be an infected eruption cyst over first primary molar. It looked pretty bad, so I placed him on amoxicillin and had him back that Tuesday and decided to incise it because it didn't look right. It drained really funny. I got concerned, and so by that Thursday we had a blood workup done, and of course you know what I'm going to tell you. It was a malignancy. Yeah, it does happen. It's quite common. I have to tell you, at least 10, 11, 12 patients in my last 35 years I've seen have had some type of neoplastic lesion that I first discovered. So it is important to do a full exam. And you have to look at their behavior too, because you never know when someone's going to turn into an arsonist in training, or as I like to say, an AIT. Treatment is determined by the diagnosis and the history. We know how important maternal history is, right? You know, maternal history often is a good, strong predictor of the type of caries history of the child for all sorts of reasons, genetic reasons, but also because the biofilm, 83% of the bacteria going to the child is reported to come from the mother. So it's important to talk about how well they do on toothbrushing, because sometimes you're instructing the parent also on oral hygiene instructions and the use of, like, let's say, a xylitol floss. And you have to stress why it's so important for them to come in for care. And then we can start with many preventive programs and products like xylitol products, xylitol toothpaste, because young children should not be swallowing toothpaste, so you have to make sure it's safe for them. A xylitol-based toothpaste like from Spry, MI paste from GC. You know, again, enamel defects is one of the biggest predictors of early childhood caries. Many good studies published on that. So we have to treat those enamel defects. That new patient I was telling you about at 11:30 this morning, numerous enamel defects, and no one had discussed it with the mom. Had no history of using MI paste. Probiotic drops, that's another very important thing. I'm a very strong believer in probiotics. We did a clinical study on probiotics showing that they were very effective. Dr. Savant Twetman just published one a few weeks ago showing the very same thing. Maternal intervention, maternal imprinting. You educate the parent. That's important. Parent education is also important. For the level of maternal education has been directly related to dental disease in the child. So the lower the education level, the more likely there's going to be dental issues. Now, if you intervene with mom and you start them on some good xylitol products, it has been shown in studies like by Isocandis and others, you can reduce the caries rate in a child for up until 10 or 15 years of age. That is phenomenal. So maternal intervention works because of maternal imprinting too. If a mother is breastfeeding, you affect their biofilm, that affects the biofilm of the child. Many, many studies. We could talk all day about this alone. But we're here to talk about dental care and Canberra and caries management by risk assessment. So we talked about the past caries history, maternal dental history, bacterial level of mouth. We do caries screening testing, which is important. So we can use that saliva testing, plaque testing, but you need to have x-rays too. And there's many times you need to have x-rays, and we can do them successfully using PSPs and utilizing our ScanX Swift to scan them. Canberra, treat the patient as an individual and according to their need. Not everyone gets exactly the same treatment. And the goal of your procedures, the goal of your preventive program is to increase protective factors, to increase remineralization, to help the child heal their own early lesions for remineralization. And that's so important, utilizing your fluoride, your calcium, your phosphate, sealants as necessary. Antibacterial agents, we're kind of moving away from that concept, aren't we, into more smart agents like xylitol-based ones. So a caries risk assessment, here's a patient who's had history of numerous recurrent caries. One of the things you want to do is see why. So we're doing the caries screening from carie-free test. We do this very routinely. It only takes a minute. Here's one of my employees, one of my staffers, Lisa. She's wonderful. She's been with me for many, many years. She's in 60 seconds. We can tell on the meter. That tells the level of ATP. And if it's the relative units, it's measuring by light fluorescence. And if it's above 3,500, we have a biofilm error, and it's at 9111. I had to take a picture of that because it's a call for help. And that's exactly what we're going to do. We're going to help that patient by smart targeting, using xylitol, for instance, and probiotics. But you can also use other dental care protocols, using like saliva check mutants from GC, a wonderful system. It takes 15 to 20 minutes, so it's usually done by your hygienist during like a sealant appointment, done by the hygienist during the sealant appointment. That's important to stress. These are things done by your staff. You train your staff. If they're dedicated, they'll do it automatically. But specific, using antibody antigen specificity for only Streptococcus mutants. As we know, for young kids, like under the age of 3, we also have to look for other bacteria, Scardovia witzia, Lacula acidua, these other species that are so important. We don't have tests for yet. Caries risk test is a granddaddy of them all, loaded hundreds of articles and references on how well it works in determination your carie proneness. It does take an incubator. You do it over 48 hours, but I have questions with this. I've used it. God bless Ivor Clark for still making it. I think it's wonderful. When we study with rugosa agar, all the lactobacilli, it could be misleading because many lactobacilli, as you all know, are probiotics. They're very good bacteria. Lactobacilli reuteri, Lactobacilli ramosus, Parasanguis, anguis, Paracasei, they're all good bacteria to help us out. Diagnodent, that's a great one. I love Diagnodent. Diagnodent can be used in all small little kids and so forth, strong gag reflexes, and we use that to actually monitor how well we do in prevention. Here's Sue. You'll see more pictures of Sue. She's one of our hygienists, been with us forever again. And she's doing a Diagnodent measurement on a molar, and we record that value, and we have it. We can see over time if it gets worse, it gets better. It tells us if our prevention program is functioning or not. But what's new, and what I am really excited about, is the CAM-X Spectra. Now this is from an ORCA presentation, caries detection using a new fluorescence camera system, using the gallium nitride LEDs at 405 nanometers, and it causes the fluorescent response. Now enamel autofluoresces green, but porphyrin-producing bacteria, they produce a red fluorescence, and they're associated with caries formation. In this article, they were very excited about this new type of caries detection age. Now, I am excited too. I have actually gone to ORCA meetings, and ORCA stands for Organization of Caries Research. And in fact, I wanted to be at this one in Brussels, July 1st through 4th, but it overlapped with the International Association of Pediatric Dentistry meeting in Glasgow. So I went to Glasgow because I had a presentation there, and I was the chair of a session at the meeting. And when we talk about ORCA research, remember, we're not talking about whales. I mean, it'd be nice to go study whales, but I haven't really been involved in treatment of whales yet. None have come to my practice. I'm kind of amazed because I'm right here in Long Grove, Illinois. You'd think they come there. So publications, yes, there's research on it. This was published in 2012 in the Journal of Clinical Dentistry in Vitro Evaluation, with 2 examiners evaluating 41 extracted molars. They took radiographs of them, they visually assessed them, they used the IC-DAS system to classify them, section them, and gave them a histological score. And then they compared the two. What they found is, non-carious teeth had a spectral reading of 1.5. It became carious, it was at 2, and they were very, very significantly compatible with the spectral reading, so that the spectra, quote, is a promising technology for the diagnosis for monitoring the progression of occlusal caries. Very good and very exciting, right? And they referred to IC-DAS. Now, if you are in pediatric dentistry, you know what IC-DAS is, the International Caries Detection and Assessment System. And you've probably been beaten over the head with this, I'm sure, but you have that ranking between 0 and 6, and you can tell early stage decay, which is decay that is remineralizable, established decay, where you can possibly arrest for a while, and of course severe decay, which is progressive. And this is an important way to look at decay, so you can actually look at it intelligently and record what's going on. Now, the one thing we have to talk about, which is again exploring old myths and so on, is the fact that since 1987 we've had a concern using explorers to look for caries. I mean, it sounds crazy, but I'm sure you've heard this, that a dental explorer can actually go into a demineralized area, wreck it, so it can't remineralize. So you're making caries happen. You're producing future caries. And another drawback is, well, you've taken the bacterial colonies from that area and you spread it. So I can see, or down the road, people are going to say, put that explorer away. Just use fluorescence for all your caries determination, whether it be a diagnodent, whether it be, the Gamma spectra. I mean, that's definitely a potential in the future because, we're doing a lot of iatrogenic damage, not taking responsibility for it. And when you look at the detection scores, it's just some pictures from IC-DAS themselves. I give them complete credit. I borrowed this from them. There's some funny studies out there I just have to share too, going back to using IC-DAS. You probably have heard that there's this National Dental Practice-Based Research Network. I love to listen to their research. There was one meeting I had listened to their results of a study done where they showed the biggest predictor for having dental caries as a dental patient is seeing a new dentist. And I thought, oh, that's really amazing. I mean, because you're seeing someone new who doesn't know that that lesion has been incipient and has been arrested and has not progressed for 10 years. And they just assume it's a new lesion. And it's a natural mistake. And the biggest predictor for how high the caries rate is in a dental practice is how busy the practice is. If the dentist is really busy, he's more likely to watch the lesion than if the dentist is not busy. Then the dentist, he or she, would be more likely to be more invasive and to restore the lesion. Now, what have dentists themselves said? And this is from Dental Advisor 2014, 2015. Here's some quotes. It's easy to use and there's no calibration required. Patients love to see the pictures of their teeth. They like the high-tech nature of the process, and it's a great motivator to follow through with treatment. It's easy to use once installed. I love that. Because, you know, installation is a lot of anything. If you don't install it correctly, it's always going to give you a hard time. So that's an important thing. Easy to see lesion with a color display, yeah. And of course, the numerical values are really, really great too. That's so important. And so again, you know, dentists themselves using it have a very high opinion of the CAMX unit. Now we go on to 2015, Journal of Clinical Dentistry, in vitro study of the diagnostic performance of the spectra caries detection aid. Now this time they used 90 extracted human molars. They looked at them visually, and then they went ahead and they used, photographed, and analyzed them using the caries detector, the CAMX spectra. Then they sectioned them and looked at them histologically. They did not use the IC-DAS. But the main thing on the result of this was the comparison of the sensitivity and the specificity. And the two are quite different. You know, sensitivity shows how sensitive it is to finding something. It's the capability of it to be sensitive to the condition and finding the condition. Where the specificity is how accurate it is, how specific it is for finding the condition. So you really want to have things to be conservative to have, you know, a good sensitivity, but you want the specificity to be high. Now when they set their study at 1.8, it was very sensitive, but the specificity fell a little bit. And so the end result is they agreed with the manufacturer at setting the setting at 2. If you get a reading of 2, that is definitely dental caries. So they use the higher threshold of 2 that's being used by Air Techniques with the CAMX spectra that discourages restorative treatment of early lesions that are best managed by sealants or other preventive approaches. And this is an important thing to remember. So with the CAMX spectra caries detection aid, you have this continuum of colors. You start with green for sound enamel, blue for the beginning of enamel caries, red for the deep enamel caries, and go kind of into the orangey and then into the yellow for deep dentin caries. And you can pretty much match that with your continuum of dental therapies you have, from watch to a little area that looks kind of funny but is green, to use of like MI-paste, fluoride varnish, MI varnish, xylitol products, probiotics, sealants, preventive restoration, preventive resin restorations, utilizing fissurotomy, ultrasonics. I love doing ultrasonic preparations. If you're not into that, you really should get into it. It's nicer than the laser. It's more conservative than the laser, more comfortable, and certainly a lot less cost. And it leaves a better surface for bonding than the lasers do. And then finally into restorative, your regular restorative. So you kind of see the continuum of treatment you can have. And I like that. It gives me real control. Now, let's look at the ScanX Swift, and let's look at it in clinical application. Again, we were talking about something that's compact and it's comfortable and has flexibility. So if you're someplace and you're still using film, then this is something really to consider. Or even if you have CCD, doesn't mean you shouldn't have a ScanX. You should, to make comfortable radiographs. Still use your CCD when you want to, when you can. But have that, like I mentioned with that new patient this morning, they should have had a PSP plate system so they could have gotten those radiographs. Why? Because you can use them as you would your old films. They're easy to place, comfortable for the patient, easy for special needs, high diagnostic quality, user current, equipment, and again, very important, low radiation. Now here's a brochure and pamphlet poster from the American Nuclear Society. You know, bite wings are 0.5 milligrams. Americans get exposed to 620 milligrams average a year. So you're not doing any harm with those bite wings. Okay? And we have a lot of posters like that in the office, similar ones, to explain to people you're not being harmed with this low radiation. Okay? Very low background. In fact, I like to kind of show you guys something here with my cursor. You may notice that every patient in this poster Not one of them has a lead apron on, which I thought was kind of interesting because this comes from the American Nuclear Society. I think when they were doing this, they had this happy glow on their face. I don't know. But, this patient's having a CT. I don't know. Maybe I would put a lead apron on, but that's just me. In fact, we always do anyway, right? Of course we do. Because we use the principle of ALARA, which is keeping the radiation exposure to a minimum as low as reasonably achievable. And that's important because after all, PSP systems get far less radiation than standard film. You take far fewer retakes than you do with the rigid CCD lesions systems. Sorry, a little slip right there for you and slip. CCD systems. So again, less radiation. Now here's Sue again, and she's one of our hygienists, but she's just a great person to work with. So she helped me with all these photographs. It's comfortable, easy to place, thin, flexible. Easy placement means faster placement, easier for the patient. The patient can bite down all the way. See how she's biting all the way, full occlusion. It's easy to use means fewer retakes, thinness means less gagging, and it's easier to take the radiograph on the other side. And you may notice that she can use anything to hold it too. It doesn't have to be a special holder. We're just using bite tabs. You can use, these are called flaps too, and there's cushies and there's sponges. There's all these things you can use to hold these without it being a problem. You don't have to have anything special to hold the radiograph. And as you know, more cooperative patients means happier staff. Happier staff means happier doctor. Now, look at young adults. I mean, you have pediatric dentistry for a while. Your practice also ages some. Of course it does. You have all these patients who just never want to leave you, and they keep coming on, and before you know it, they're having their own families or coming back with their kids, and it's so wonderful to see them. It really, truthfully, is great to see them. And you're able to get good views of the third molars, because you can keep placing them more distal. And that's really impossible. Well, okay, it's really hard to do with the thick CCDs. Again, good views, that comfortable. It can be done, but it's much easier to use a PSP system. And easy things are what we do right now. This is an old photograph. No, that's not me in dental school, guys. Come on. I'm not that old. Anyway, here we have a dentist working away on a patient, and you may note that he has his knee for support on either the arm rest or maybe on the patient himself. And the patient has his hand up on the dentist's ear, and he's saying to him, "Hurt me, I'll rip off your ear." I don't know, maybe that's not the case, but it kind of looks like it, doesn't it? How about our medically involved patients? Here's a patient with Cornelia de Lange, and by the way, just as a side note, all these patients signed consents, and they knew exactly what this was being used for because they're very involved in the practice and trying to educate people too. And this is a rare genetic disorder present from birth. It causes a range of physical, cognitive, and medical challenges. It's named after a Dutch pediatrician, Cornelia Catharina de Lange, who first described it. In this patient, we had to make a decision on whether or not to do a general anesthetic and take out the third molars, and possibly there could even been a couple of little lesions. So I felt like I really needed to have these x-rays. But, it's one of those things where, as you see, I'm looking straight at the assistant, getting ready to say, take it quick, because you can see the patient's hand there too. I mean, she's very cooperative. I want to stress that in many ways, but a lot of these patients, they're difficult patients. They stay in pediatric dental offices because we are the specialty of a lot of disabled patients. And you have to make things easy for them and comfortable, and this certainly does do the trick. I'm ready to take the radiograph, and I slide it in, because as you know, timing is critical. Many patients aren't patient. I had to get that radiograph. And so, we do have a little movie here. We're going to watch this just for a second or two. It was absolutely necessary to get these third molars before scheduling any time in the operating room. I didn't want to schedule it and then end up not needing to do something. I have never walked out of the operating room saying to someone, "Oh yeah, we just cleaned their teeth and took some x-rays." because I've always had a good reason to be there. And so if you look at the video here, I'll click on this, and it just was this getting her to, I'm talking her through, I'm talking the whole time, I'm talking her through, I'm using a regular snap array to do it, I'm holding it in position. I felt like I had to get this. I'm saying, okay, take the x-ray, bang, we're done. And that was it. So it's something I felt I had to do. And then here is actually a general anesthesia case at the office using mobile anesthesia, which is a physician's group of anesthesiologists that come to an office, and I'm treating a patient with Down syndrome and get very small maxilla, but I can get good radiographs. I'm using a Nomad here to take the radiographs, and I'm protecting my hand by using the lead apron. It's a zeolite apron. But again, I'm using a snap array and take really good radiographs and get it done very quickly. I have great looking hair in that picture. And I'm thinking, well, that's such great looking hair. Maybe I should run for political office. I'd like to have a survey at the end of this presentation. How many people think I should run for political office? Because I do have good hair. That was just a joke. But here I am doing treatment under general anesthesia. Unless you guys are really want to support me in my run for office, each just send me a little small envelope with a few $1,000s of unmarked bills, and I would consider it. So that'd be $700,000. I think I could do that pretty easily. So here's a patient with ASD, autism spectrum disorder. Again, we're using PSPs. We're going to scan with a ScanX Swift. Fast capture radiographs means what? Less time under general anesthesia. If you look really carefully, you can see the nasotracheal intubation right here. And mobile anesthesia is all the way against the wall. And we had set up that room to do our cases. And it's very, very convenient for the patients. And it's very, very nice. And we have had nothing but wonderful, wonderful times with us, working with them. Now, Sue here is just going to demonstrate really quickly about taking it. Now, because there is no cable on this, we don't have to worry about breakage of the unit. She can position the patient, place the PSP, and go in and take the radiograph very nicely. Now, it's a low dose, so the operator only needs to be 3 feet away from the equipment for nearly a zero exposure. I know it sounds really crazy to you guys, but we get inspected here in the state of Illinois. In the United States of America, we have radiation inspections. Our radiation inspectors come in, and they have often stayed in the room when they inspect our units and our settings, and they say stuff like this to us all the time. You don't need to use your lead aprons. Your settings are so low because you use good software, good scanners, good PSPs. You don't need to use lead aprons. We do anyway, just to make the patient feel better. And yes, we step out of the room as way as we can, as often as we can. But if I have to stay in the room for a reason, I do. I discourage it though. Then you scan this PSP with your ScanX Swift, and it just requires a very small footprint. This is a very tiny shelf that we actually put in our server room, okay, because it just happened to be centrally located. Now, I have to tell you, we have 3 different scanners in the office. We have been digital radiographs forever. I think when it first came out, PSPs, we went to digital radiography. We use X-ray vision from Apteryx for all of our devices to capture all of our photographs, all of our radiographs. And we probably are going to a cloud-based practice management software, but we're going to keep our images local on our servers. And so Sue's just going to demonstrate to you really quickly how she just runs that through. There goes Sue. She's just clicking open the patient. When she acquires the patient, she's ready to acquire the radiograph. You can see the ScanX Swift is blinking. It's all ready. The biggest amount of time it takes is the removal of the infection control sleeve. That's it. And that's not going to change no matter what you use. It takes a little time to remove the sleeve. It's already scanning. Look at the screen. You can see it scan through. And you see it's getting ready to do the auto erase because you got that red light showing it's going to erase as it comes down. And she's already struggling opening up the second one. She's getting ready to put the second one in because the first image has come up. And now here goes Sue. She's putting in the second one. See, the image has come up. She's putting in the second one, and that's how fast it is. And that's running at high resolution. That's not running at the low resolution. So The radiographic image is then placed in X-ray vision from afterwards. You can use whatever you want. But look at the small space. You can put it in any central location. You can move it too. We've shown that in a different video we have. You can go ahead and move it and place the ScanX anywhere you want to, as long as you have a workstation it can connect to right next to it. But you can take the plate. Now she's going to go ahead. She's got it in there. She's just doing a little correction of it. She corrected some things she wanted on the gamma. Super easy to do, and it is done. And that's how quick it is in real time. And here's a high resolution radiograph we have. And this is again another case for us to look at. Patient with history of severe gag reflex and obstructive sleep apnea. A little guy. And he had snoring all the time. He had huge bags under his eyes, more than any lines. You could tell he's a strong mouth breather, developing open bite, bilateral cross bite. So we don't wait on those. I expand them with a quad helix. I get maxillary expansion, get them out to normal. That's the band we just left on after we had done that's where the 3D attachment. Look how nice and, I mean, it's probably hard to tell on your end, but that's a very high resolution radiograph. I'm sure it's been decreased some going over the internet and being compressed down for this presentation. And we also had an ENT consultation done. We had the adenoids removed. Young man symptomless now. Doesn't snore. He's grown like a weed growing. Face has changed. It is so important to do that. And yes, we can get radiographs on him. This is the #1 film shot without any difficulty at all. Didn't bite down really hard on the little bite flap, but hey, I can see everything I need to see on someone who couldn't even have a fluoride treatment without throwing up or have his teeth cleaned. So huge improvement, right? Other severe medical issues. This is a patient that I treated that was referred to me from overseas. We did have the one eye block to kind of give you and hide the identity a little bit more. Of course, the face is covered for protection of the patient. That special gauze, especially impregnated with coconut oil, because this patient has recessive dystrophic epidermolysis bullosa. Now, this is in the hospital. I was doing this at Anna Robert Laurie Children's. I did not have any PSPs available for this. All we had was CCDs. I couldn't get the radiographs I needed. I wasn't happy. I was kicking myself. I didn't bring some Air Techniques PSPs from the office so I could at least take them back and get them scanned later. Oh, by the way, I left the one eye uncovered. You can see there's a special ophthalmic ointment to protect the eye. I wish we had time to tell you the setup for kids with recessive dystrophic epidermolysis bullosa. This is one of the things I do present on a number of meetings. We have a specific protocol for the care of these children. And I see it's a rare condition, but I see so many. I have a rare condition. I have had two of the same condition in the same day. It's just, here's a young lady, also recessive dystrophic epidermolysis bullosa. She's at maximum opening. Her mouth looks bigger than that. Her mouth looks bigger than it is because her lips are all bloody. So you can't really see it very well. All sorts of special precautions we use. We have specific setups. I can get done with these cases and there's no bullseye. There's no blisters because we know what to do. We know to use the Carapace suspension in the mouth. We know where to use KY jelly. We know where to use coconut oil. We know where to use all the specific stuff, the polymer membranes, all that stuff that's supposed to be used, the special donuts, everything. And we do it very carefully. We do all sorts of special precautions. But one of them is you have to use a PSP, and you have to use special sponge covers to protect the PSP. You can't do it with a CCD. Sorry, can't be done. Now, one of the things, too, that's kind of cool in pediatric dentistry is the Nomad Pro 2 from Arabex. Over 12,000 are now in use. I think that's great. They're lightweight now, less than 5 pounds. They're great for caring for patients with special needs because you can move them around any position very easily, using them in operating rooms, going back and forth between the operating room, going from operatory to operatory. If I were to start over again, I don't think I'd buy as many wall-mounted X-ray units. I'd probably do more of these portable units like the Nomad. Portability that's not being tethered. Now here's a young man in an open bay, a dental open bay. Yeah, you can take a radiograph on him. See, his mouth is completely closed on the PSP. There's no cables, not any at all. The hoses you see in the background are from a dental cart, but there's nothing tying us down. You can get any angle anywhere you want to go. Isn't that marvelous? And in fact, it's so cool, you can take 2 sets of bite wings at the same time. Just line both patients up, put the radiograph tab in, both of them, and go beep. It's a joke. I'm kidding. The little girl in the middle, she's so cute. She's looking up there saying, what are they doing to my brothers? But that's just in one of our open bays at the office. And you can tell it's a pediatric practice, right? You can see up here we have Maleficent and Ariel, the Little Mermaid. But here we are, showing the portability, which is so important. Now, CCDs have a cable connection and require a workstation right there. That's not the best for kids. Now, this is a dramatic reenactment of true events. This happened to a colleague of mine. He told me all about it. Now, his assistant was walking out of the room saying, now hold still for your x-ray. And this is what happened. There went about a quarter of a college tuition. The young lady picked it up and threw it on the ground and went smashing down. Oh, yeah. Let's do a replay. Let's see if we can do a replay of that. There he goes. Takes it and she throws it down. No, we can't do a replay. Oh, yep, she did. So, in all honesty, that was a reenactment. So, radiographs should be a walk in the park. Isn't that like fun? You know, in Chicagoland, we have short summers. Both weeks of summer go so fast. You like to be outside. So let's just go outside in the park and take some of our radiographs, right? Not an issue at all. Oh, by the way, at the end of this, you'll see that there's a little disclaimer that no CCD sensors were harmed in any way during the filming of this webinar, just so you know. Again, a joke. Because after all, you have the choice of it being a walk in the park or maybe a run in the office. And this, too, is a dramatic reenactment of a true event relayed to me by a colleague as the patient went running, swinging the CCD up and down the hallway, smashing it against the wall. And that is actually one of my second-generation patients who was more than happy to cooperate. Doing that, loving it. So, CAM-X Spectra. CAM-X Spectra is really cool. It's a good caries detection aid. And I'm explaining this to a preteen patient, describing the importance of fluorescent by pathogenic bacteria. I got a little movie of it right here, but I'm not really going to play the movie because of time. But also, I sounded pretty stupid. I kept watching this movie saying, that's really kind of stupid. I'm doing something I'm not usually normally doing when I was filming this. And it just came across kind of stupid. So I'm not going to play the movie. But this is what she was looking at when I showed it to her. Here's your CAM-X Spectra image. Now this is in our, again, from Apteryx, our X-ray vision, and whatever software you have or your images you can use. But it shows the bacterial fluorescence. Remember, green is the autofluorescence of the enamel that's normal. And you got that red, that's the enamel decay starting in the surface of the tooth, and you got that yellow, which is going down to dentin decay. So there you go. And you get numerical value on that too. It's kind of hard to see in this. But you save these images. So yes, if you want to just watch a lesion or try remineralization with like MIPAs from GC, you can do it and see how well it works. And you see the whole tooth at one time, which is a big advantage of CAM-X Spectra over Diagnodent. You actually have the image. Oh, I love it. I think it's so cool. So here I am scanning the molars prior to restoration or sealant placement. Of course, if you have hygienists, they should be using this before they do their sealants, right? If you have hygienists who do your sealants like we can use in most states of the United States, they should be doing a CAM-X Spectra before they seal, just to make sure you're not sealing any caries lesions. It gives validation to your system too, doesn't it, of what you're doing. Now this is me reviewing the image on a workstation, and I'm able to relate the information directly to the patient right there. And the patients like to turn around and look at the images too. I say, hey, look at this little spot. See this little spot? It's the beginning of a cavity. You have to really work on this. Let me see, Dr. Cam, and I want to see. I've actually ended up sending images to patients who put it on their phones. Now this has been determined to be a black little spot. The tooth had been sealed. This is a 6-year molar on like a 14-year-old, and the sealant's really worn down. But we decided just to watch it for a while. I'm just going to take that sealant off and replace it. It's not really carious. It just could stand a little replacement. Probably do a little fissurotomy, clean it up first, and then reseal it, or do a preventive restoration. This is a molar after restoration. That little bubble you see on the top, that's just a little saliva. But all the carious pits and grooves were removed, and this was all restored with Activa from Pulp Dent. And this shows excellent marginal integrity. I really love to use this to evaluate restorative care. Man, you can really see the difference too after a few months or a couple years coming in. And Activa has been a product I've been using for a very, very long time. One of the evaluators long before it came to market, and one of the people who were interested in pushing for it for years with Pulp Dent. And I love the guys at Pulp Dent. They're very, very good at following through and making a great product. They really have with Activa. Excellent marginal integrity. This is a molar that was treatment planned by another dentist for a restoration. And I just said, now we're going to do a watch on this. We're going to do our remineralization protocol. And by the way, look at the numbers around the sides, around the tissue. Those are porphyrin-producing bacteria, right? We're going to talk about that some more in just a few minutes. So here's another case. This is a great clinical case right here of a 70-year-old male patient who presents for pit and fissure sealants on a restoration of second primary molar. And we took a PSP radiograph. It was obtained. Now he has a severe gag reflex, but he was able to do a PSP, okay? Now we're using nitrous oxide analgesia for the restorative because of the severe gag reflex and also the history of having been very uncooperative for previous dentists. He's been great for us though. Now we're using nitrous oxide anesthesia, and we're going to use stay local anesthesia. So with the nitrous oxide we're using from Porter, the Silhouette Hood. You see that nasal inhaler? It's really nice from Porter, and I really recommend that for people if it's very nice. It doesn't get in your way. And we're using from Milestone the stay unit for stay anesthesia, and that's single tooth anesthesia. We numb just the tooth, not the face, so we don't have to worry about lip bites or any other issue. I love it. I've been doing that ever since that was available too. And just to show you for grins, you can see there on the spectra image, the 2 right there, that's that mesial caries in the second primary molar. And the first primary molar actually looks great and has a restoration I had placed before. That's an Activa restoration. It looks fantastic. And here we go. Now I just placed an Activa in there to fill it all up there. I have to do a little polishing around that one corner, as you can see, but that looks so much better. Again, you got a really great looking restoration, no more curious involvement of the dentition, so you can kind of validate yourself. So with the CAMX spectra scan here, this is prior to sealant. This is important to say, hey, we can seal that. That's not a problem. But maybe we should think about perio-evaluation. I'm going to go off the reservation a little bit here and go a little crazy with you guys about utilizing this new system that comes. I got a little pop-up here, and I just got 5 minutes here to finish up. Oh, he added some time, so we got time. That's fine. We got plenty of time to talk about this. So this is using prolaxin in PhotoSand from CMS. Sorry, I had to talk back to that little pop-up window that showed up. But this is a great system. It utilizes a vital dye, the PhotoSand blue agent, they call it. It's no longer blue, it's yellow. But you can go in and you can, a person that shows a beginning of periodontal disease, you can inject this around the sulcus, into the sulcus, and then you shine a special light that they have. And this is a light that, it's like a curing light that has a special tip, and it vibrates up the PhotoSand to do light-activated disinfection. And in just a few seconds, you kill off all the porphyrin-producing bacteria. And you're saying to yourself, porphyrin-producing bacteria like what? Porphyromonas gingivalis. Good old PG, Porphyromonas gingivalis. You remember him? And he's the guy with the periodontal disease and causes the heart disease. And PG can grow directly on your endothelial cells and your heart and your arteries and cause all sorts of issues. They have a little pedia that allow them to attach to all sorts of human cells, or they invade that way. But the funny thing is, when you use this light, you're doing it. What you see, I'll use a cursor, it's kind of hard for you to see, but you see the glow of the porphyrin-producing bacteria everywhere, just like you do with the CAMX spectra. Talk about validation. This is why this person has perio. Now, how's this for a concept? How well does tooth cleaning work when you're only cleaning the teeth? I was just at a meeting, the AOSH meeting in Dallas, where I was the afternoon keynote speaker in a room, and the periodontists were often talking about the fact that they can treat the perio in the teeth, but they are missing all the periodontal bacteria which naturally grow and attach all the soft tissue. So it's inside the cheek, it's under the tongue, it's back in the vestibule. You see that with this system, just like you can see it with your CAMX spectra. And then it kills it in just seconds. I mean, they say 4 to 5 seconds. There's a special tip. You can see the glowing piles of bacteria as they glow, and you're killing all the porphyrin-producing bacteria. And then after you get done with that, you rinse it off, and you go ahead and you inject your probiotic in the area. So you see, I can see in the future using the CAMX spectra and not using your perio or your Caries Explorer or Dental Explorer as much, finding all these early growths of all these pathogens, going in and removing them, not just from the teeth, but from the periodontium too, and then treating them with a probiotic. And this is bacterial replacement therapy. This is so cool. It is the future of our specialty. So, I want to sum this all up. I want to thank you all for your kind attention. I sincerely hope that giving you a few ideas of some of the future of our specialty, and that you can use these superior diagnostic capabilities like the CAMX spectra unit and be able to get the really great radiographs you need